Okay, everyone, might get started. Can everyone hear me okay? Fantastic. All right. It's a real privilege of mine today to welcome all of you to this Continuous Improvement and Implementation Science Day. This is the concurrent session, Aboriginal Patient Journey Mapping Workshop. So really pleased to have you all here. What a great turnout. Thank you so much. Okay, importantly, before we get started, I'd like to acknowledge that the land of the Adelaide region that we're meeting on today for this workshop is the traditional lands owned by the Kaurna people. I'd like to acknowledge our gratitude that we share this land, our sorrow for the cost of that sharing, and our hope that we can move to a place of justice, reconciliation and partnership together. I'd like to pay respects to elders past, present and emerging, and I would really like to extend that respect to all the Aboriginal leaders and colleagues that we have here in the room today from the different lands, which I can see many of which I'm really, really pleased about, so thank you. I'd also like to acknowledge, importantly in the context of Research Week and what we're presenting on today, that we'd like to acknowledge that Aboriginal and Torres Strait Islander peoples are indeed the first researchers, and they're the holders of the world's oldest, continuous and most sustainable culture. So important to it that we make that acknowledgement as well. Okay, so like I said, an absolute privilege to be hosting this workshop today. It's something that I've been really wanting to do, and I'm just thrilled to see so many of you with us. So I think the value that this can bring to us this week is that this is a really practical way that we, to be able to use these tools is a really powerful way that we can begin to understand and unpack our patient journeys, but particularly with Aboriginal and Torres Strait Islander peoples, which we know, we often don't do well. And it's not through the fault of individuals, it's the system itself that doesn't enable us to, really view that journey in a holistic way in which we know that that's what the power of how we need to be managing our kind of patients that come through the doors. So today we're going to take you on a little bit of a journey in itself. We're going to unpack a bit of the context around the health journey mapping tools, which some of you, may have seen, may have tried, may not have seen. So really this, idea of this workshop is to give everyone an understanding and provide a bit of an introduction to what those tools are, what role they can play in healthcare, and how we can apply them. So we're going to go through that. We thought it'd be really useful to mix it up, and rather than lots of presenting to you, we'd bring you along and we'd do some practical work around a couple of case studies that are relevant to our context. And we're going to look at that through the clinical tool and also have a bit of a go as a group working through and having a feel of the detailed journey mapping tool and the strategic mapping tool, which you'll hear more about in more detail shortly. And then we'll have a bit of a group discussion followed by a bit of a wrap-up, next steps, and of course, importantly, the opportunity for people to ask questions. So we've got a jam-packed schedule. We could have done a day workshop on this. We've got an hour and a half, so we'll see where we go. But I think this is probably, as we were talking about earlier with the group, this is sort of the seed, if you like. This is where we start the sprouting, and who knows where this can take us. But I'm hoping that this is the start of many more conversations with not only those of you on the room and those of us joining us online, but into the future as well with other colleagues as well. So it's an absolute privilege to sort of provide a bit of an introduction to the team that will be presenting today. So for those of you that don't know me, that haven't received the myriad of emails promoting this session, my name's Jessica Stott. I've got the privilege of being the Silent Advanced Research Coordinator here. And I've roped Derek Francis, who many of you will be familiar with, to come along on this journey as well. And Derek is just, commencing as an Aboriginal health practitioner out in the Aboriginal Family Clinic after a very, very long time in Carpenter-Attendee. So he'll be co-presenting, real privilege to be with him today. And then, of course, wouldn't be here without the fabulous team from the University of Adelaide. Certainly want to acknowledge Janet, Associate Professor Janet Kelly, who has been, this is all her baby, I guess, fair to say, who unfortunately couldn't be with us today to present, but has certainly been supporting along the way. And then we've got Amy Graham, who's project coordinator with the Adelaide Nursing School, a proud Ghana Narungga woman, so really privileged to have you. Thank you, Amy. And her colleague Alyssa Cormick, who's a research assistant also with the Adelaide Nursing School, who's done a lot of work in the background with some of these, with the tools as well. Okay, so enough from me. I'm going to hand over to more of the experts in this space, and we're going to start to hear a bit more about the scene setting of the tools and a bit of the context and the application to health.
Oh, how do we put the YouTube video on? How do we do the YouTube video? Just click it. Just click it.
With Google Ads, your ads can reach people who are looking to buy exactly what you sell. We saw
Aboriginal and Torres Strait Islander peoples have a right to enjoy health journeys that are culturally safe, responsive to their needs and of high quality.
Therefore, Aboriginal and Torres Strait Islander patients and family members, health professionals and managers across Australia have informed the development of a unique set of health journey mapping tools that identify both strengths and gaps in care. These tools can be used in hospitals, clinics and primary healthcare settings to collaboratively identify and prioritise care needs.
People may experience complex healthcare journeys due to distance, difficulty accessing care, communication barriers, and having more than one health condition. They often navigate a confusing and disjointed health system, while also meeting family, community, work, and study commitments. Health professionals and health services strive to recognise and meet complex healthcare needs, but often find this challenging in busy clinical settings. Interactions and care planning is further complicated when health professionals and patients have different priorities, understandings and worldviews.
These tools can assist staff to embed culturally safe and responsive care into clinical practice and provide evidence of this which can be used for accreditation.
They align closely with 3 of the quality and safety standards, which include partnering with consumers, comprehensive care, and communicating for safety. The tools provide a structure and process to map journeys, identify strengths and gaps in care, develop improvement action plans, and review effectiveness. The tools are based upon underlying principles of equity, safety, and partnership, using a strengths-based approach and two-way communication to co-design improved care.
There are 3 different tools designed for 3 different purposes. These are a clinical tool, detailed care planning tool, and a strategic mapping tool.
A clinical tool is for use in a busy clinical setting. It quickly identifies care needs and priorities and can be used for assessment, admission, planning, and transfer of care.
A more detailed care planning tool provides a more comprehensive understanding of what is happening for a patient or client in healthcare in their life and what is needed to ensure optimal health and well-being outcomes.
A strategic mapping tool that brings together the multiple perspectives of patients, clients and their family members and of the health professionals caring for them. Each tool is accompanied by an education package that explains how to use the tool by providing practical examples of how other health professionals have used the tools to improve care and additional resources and links.
Why is Clairol Root Touch-Up number 1? Because nothing blends better. Root Touch-Up is...
Close that. Let's see. name's Alyssa. I was one of the research assistants on the team that helped develop these tools. So this health journey mapping resource was co-designed with First Nations patients and family, and First Nations and non-First Nations healthcare staff, managers, researchers and educators. So by collaboratively designing these tools with end users, they helped guide the focus, content and format of them. And this resulted in 3 tools: the clinical, detailed and strategic tool, an educational PowerPoint and videos which help explain the concepts and how to use them, and some worked examples. So health journey mapping is a way to record, plan for and summarise or review health journeys. So this means that you can identify strengths and gaps in care, but also come up with some strategies to improve them. So this can help make sense of complex journeys and can be conducted to plan upcoming journeys, map journeys in real time, or to review past journeys. You can bring together multiple perspectives, so patients, their families and different healthcare professionals, and you can compare journeys to evidence for accreditation and standards and policies. So here's a little example of what a health journey map could look like. This is a simplified version, but it just shows how in someone's journey you could identify different stages, what's happening in their health journey, what's happening outside their health journey, strengths and gaps in care, and strategise to make some improvements. So this enables a holistic and person-centred approach, promoting positive change. So the 3 tools that we've developed are the clinical, detailed and strategic. So the clinical tool is a really simple one you've got on your tables, and it's meant to just be picked up and used. So this is for busy clinicians in everyday clinical care and follows the process plan, do, study and act. The detailed tool is a comprehensive planning tool, and this follows the stages look and listen, think and discuss and take action together, and then review. And so this one enables you to map and go into further detail of specific focus areas in a patient's journey. The strategic tool is then a higher level tool and brings together multiple perspectives, and it's used to map different stages of a patient's journey. So here's the clinical tool, and as you can see at the top there's the plan section, so you plan the mapping process, get some information about the person whose journey you're going to map. Do, you collect information about what's happening. Study is interpreting these results. Acting is planning and recording potential actions to address the situation, and then you review what happened. The detailed tool follows the stages look and listen, think and discuss, take action together and review. So like the clinical tool, the look and listen stage, you just put information about the planning and how you're going to conduct the mapping. Think and discuss is collecting information, and so along the side you've got different focus areas and you collect information about them. You then take actions, you prepare to make action based on these information, and then you can review the effectiveness of it. And the strategic tool is quite similar to the detailed, except it goes through different stages of journeys and brings together different perspectives. So some specific examples of how these tools have been used to map journeys before, during or after is before a patient journey, the tools can be used to plan, so plan an upcoming transfer from Port Augusta to the RA. So they could be used to support specific patient cultural care needs and logistics such as transportation, accommodation and finance needs. During, so currently journeys of adolescents transitioning between the women and children's and RA are being mapped in real time. So specific needs and support of these individuals and their carers are being mapped, and then specific ways of how you can identify and address these coming up. And then an example of how the tools have been used to map journeys after they've happened is at the RA in the Wellbeing Hub. A review was conducted and it was on a near-miss journey, and they failed to identify any specific times in the journey where things had gone wrong, but then by using these tools they were actually able to get much more in-depth information and identify specific gaps and ways to address them.
I'm Amy Graham. Thank you, Jess, for the acknowledgement, and thank you for inviting us here today as well. So, equity, safety and partnership, these are the underlying principles for all three tools. The reason why we have these three principles in particular is because these were the themes that came out when we were doing consultation and co-piloting the tools. So often in healthcare we provide people with equal care. However, equal care doesn't always mean the same health outcomes. People often come, they're often entering the health system from a different stage, different resources and different statuses. Equity can be achieved by building upon existing strengths and resources to ensure that everyone is receiving same care outcomes. Safety is achieved through two-way communication, working and collaborating respectfully with one another, and then also reflecting on the interactions that we've had with other people. Partnership is achieved by co-designing processes and strategies together, and to make sure that we are working together. Oh, how do I? Thank you. So, definitions of health. Biomedical model of health can be essential for diagnosing and treating disease. However, it focuses on recording a single episode of care instead of looking at someone's journey in their holistic health. It's not often inclusive of social, emotional and cultural factors, which we know impacts healthcare. The holistic definition of health is inclusive of the interconnected relationships that we have in life. And therefore, health is not just the physical well-being of an individual, but refers to the social, emotional and cultural well-being of the whole community in which the individual is able to achieve their full potential as a human being, thereby bringing about the total well-being of their community. It's a whole of life view and includes the cyclical concept of life, death, life. What normally happens in healthcare, I will, as an Aboriginal person, not as a worker, just as an Aboriginal community member, I will walk into a healthcare setting, see a doctor, see a nurse, I'll often sit down. The healthcare professional normally directs the way in which healthcare is received. They'll normally tell me what I need to do and how I need to do it. Normally I'm sitting there and I'm listening and I'm trying to kind of decipher what is happening, and I don't get a say. I don't get to tell you what my strengths are and what helps me become a better person. So for optimal care, what we need to do is we need to be creating an even level playing field. We need to get rid of the hierarchy status that we sometimes naturally may have within a healthcare setting, and that allows the two-way conversation. So all three tools, as Alyssa was saying, they're all linked to the accreditation standards and CQI. They are particularly with Standard 2, partnering with consumers, Standard 5, comprehensive care, and Standard 6, communicating for safety. All tools specifically linking to the NSQHS Guide for Aboriginal and Torres Strait Islander Health, and they all involve a process of CQI, which is driven by the Plan, Do, Study, Act, and then Review. So linking the tools to the national standards was an outcome from us co-designing the resources with all of our end users. Our end users were middle management, acute care and primary healthcare settings, clinicians, nurses, midwives, clinical workers and Aboriginal health practitioners as well. We know that you guys are busy. When I say you guys, I mean clinicians, anyone within an acute care setting or primary healthcare setting. So that's why we've linked them specifically to the standards for better uptake. How to access the tools. At the moment, the tools are accessed through the Lulcher websites. You need to become a member. Yep. You do need to become a member to access the tools. Membership is really, really simple and easy. You literally go onto the site, enter some details, and you'll become a member and then be able to access the tools.
Yep. Thanks, guys. So that gives a bit of the scene setting. Now we kind of want to mix it up a little bit, and we thought this is where we get to have a bit of a look and feel with the tools. So we've got our first case study, which, for those of you that are online, you'll be supported to do this as well when we break off into our groups. But I'm going to hand over to Derek now, and you'll see on your tables, and those online, it's within the Hoover app There was a link to the case studies in there as well. But if you refer to case study 1 on your tables, and Derek's going to introduce and talk a little bit about this is, and again, this is an actual patient. It's yeah, not made up. It's real.
Okay. Yeah, thank you, Jess. Thank you, Amy and Alyssa. And yeah, thank you all for coming. Like Jess said, yeah, I've been with Salin now for nearly 16 years, and all based here at FMC. And as from this week, yeah, sadly leaving, but commencing a new journey as an Aboriginal health practitioner down at the Aboriginal Family Clinic at Nalunga and at Clover Valley Park. So, and who knows, it could be back at some stage. But yeah, thank you to give me the privilege to present these case studies. So yeah, we'll do the first one that's around the clinical health journey. So yeah, we've got a traditional 50-year-old Aboriginal man who lives on an outstation that's 1.5 hours outside of the closest community, which is Maningrida up in Darwin in the Northern Territory. And Maningrida is located 500 kilometres east of Darwin in Arnhem Land. So yeah, long way. And yeah, during the wet season, which is coming up there at the moment, yeah, people can be cut off, and in particular this patient was cut off from his community to access his local healthcare due to the flooding. So, and yeah, the patient was known to have, I guess, a bit of a mix with his compliancy around his health as well, due to, I guess, the flooding. So yeah, the first presentation, we're just using made up initials here. It's not real. So yeah, patient presented to his local clinic in Maningrida in October 2020 after developing left-sided chest pain. He was diagnosed with an anterior STEMI, care flighted to Royal Darwin and had a stent to his LAD. Discharged 8 days later to the hostel for follow-up with the NT cardiac, and however he presented the second time in mid-November 2020, and he was readmitted with shortness of breath. So on arrival he went into cardiogenic shock and transferred to ICU and was intubated and developed acute renal failure as well. The patient was then transferred from Royal Darwin Hospital to Flinders Medical Centre for mitral valve replacement. He was able to have his brother travel with him as an escort for support, and that was very critical for that. And then discussions commenced around which valve sort of selection, and I was able to discuss that with family, the local community clinic, and the NT cardiac coordinator as well. So yeah, those were important for them to have that input. The tissue valve was identified as a preferred option, so he underwent the mitral valve replacement on the 25th of November 2020. Extubated on day 2 and transferred to the ward on day 7. The patient was then discharged back to the NT from day 13, where he had an NT cardiac review before returning country back out to his community, Maningrida.
Okay. So this is where we want to get a bit of a feel for like I said earlier, the tools themselves. So you've got the clinical tools. I'm going to come up and support those online, but we've got these guys here who are going to, be happy to float around. But we want to see you guys, work together. Some of you might not know each other on your tables, but that's, provides sort of the perfect platform for working in teams as we do in healthcare. To sort of start working through and having a look at how you could apply that case study to a clinical tool, and get a bit of a feel, and we'll go around and help you out.
I think this is going to...
Well, I could put it back to that slide that explains it. I was saying, do you mind if we flick back to a different slide?
Yeah, of course. I'm just going to go and join.
This is where we fill the gaps in between.
Okay. Okay. I hate to, sounds like from where I was sitting with the online people, that sounded like some really great discussion. So I hate to break that up, but in the interest of time, we just thought we might be, it sounded like these guys felt really encouraged. There was lots of really good, productive conversation. Did we want to have a bit of a feedback as to how people were thinking that felt? And, yeah, what are some thoughts? Do people want to share them? Did you guys have any observations, or just open it up to the floor?
I think the last thing that we talked about was that having this particular... Shall I take my mask off? The last thing we talked about as a group was having this mapping tool would be extremely handy going forward for any of our future cases. We talked about how we'd had a case last week that sort of was rushed in for an emergency procedure on the public holiday, and we just sort of made it happen, whereas if we had all of this information in front of us and had it mapped out, everyone would have been on board with it, and it would have been actually really, really handy. So, I mean, that was our last takeaway from it, I think. Yeah,
fantastic.
yeah.
Great. That's excellent. I'm really pleased to hear that, and already feeling like you can take something practical away in implement. Yeah. That's fabulous. Anyone else have any ideas? And I like that you thought of a case study of your own to apply. Yeah, should have encouraged, people. They didn't have to follow script. It's a bit of a free range. Does anyone else have any other thoughts just on this one?
We thought it might be useful to, in terms of who completes it.
Yep.
Is it something that's, obviously if we're role playing that we're currently based in Salem, but that it's a three-way sort of, process that we're engaging with the community service back in Maningrida. So, and then obviously with the patient and then, thinking about interpreters and that sort of thing too. So. Yeah, we just sort of had a bit of a discussion about, that process to ensure the continuity.
Another point too is that it raises questions for the clinicians to check. It is a great tool because it raises those questions. Think, we didn't think of that. Oh yeah, this is really important. So, and I think also the more questions it raises, the more you can then as a clinician reflect on what it is that I need to be doing, or what services do I need to build relationships with to ensure that this patient gets back to community safely. There's also the stuff around the follow-up medication. Does the patient understand the language that's being used? Do they need an interpreter? Do they need to speak to a male person? So all of those things, and particularly around the interpretation, or we've got services that will bring in Italian speakers or bring in other speakers. It's really important that it's supported at Aboriginal languages, and people will get supported to help this patient on their journey as well.
Yeah, that's great. That's really good examples. Oh, you got another comment? Yep. You've got one more.
I just thought it was worth noting that I guess we spent quite a lot of time in the first column, and I guess this man was very medically unwell. So yes, I guess, most of the time the first thing we're dealing with in the hospital is what the medical issue is, but you're not sort of thinking whose perspective is that coming from, which it's normally always our perspective, or the medical team's perspective. So to sit and think about what else is going on for this person and other perspectives that come into play, not just a medical perspective, because that's how we're led here, is just the biggest eye-opener, I think, for me.
Can I just respond to that, Jess?
Yeah, absolutely.
Thanks. So thank you for that comment, and I think it brings it back to the biomedical and your holistic healthcare. I think as clinicians we're often taught, what is important right now. We need to get a person seen by a multi-D team, we need assessments, we need x-rays, whatever. That's completely fine and that's completely justified. But what's important to me when I'm laying in that bed is not what's important to you guys. We need to be able to marry those two. We're talking about saving people from early discharge. You get early discharge and then get re-representation down the track from the patient. How do we prevent that now? How do we make sure that patient knows that they're mattered, and it's about identifying that person's strengths. I know what my strengths are. I know what's going to keep me strong when I leave this hospital. You know what's going to keep me strong medically. How can we bring them two together? And I think this tool allows that. in a real time. And I know there might have been a little bit of confusion in regards to the case study and the tool, and are we doing this before the patient comes, after the patient comes? So the clinical tool has been designed for people to sit bedside, sit at the table, have a cup of tea. Always have a cup of tea with someone. Sit at the table, have a cup of tea, go through your list. You can take time on this, or you can use it as a 5-minute tool just to quickly see what matters right now.
Thanks. Okay, no. Yes.
I can see it building capability as well. You know, as you have these discussions within teams, you know, you can see that people's, you know, understanding of and their cultural competence in practice will increase because they're engaging in these collaborative discussions and thinking about it more proactively from the cultural perspective. And it really reduces the risks of clinicians making assumptions, you know, on someone else's behalf. So, yeah, I think it's really good.
Great, that's excellent. Pleased that everyone found that so useful, even just in that short period of time. Oh, sorry, yeah, Jay.
Sorry,
no, that's all right. That's okay.
It's more a comment, really. I think this will, you know, like everyone said, it's making us think about things from all the different perspectives, but I think it will also tie in really nicely with the goals of care work that's happening about, you know, what matters to you or what matters to me. So I think it's a really nice
segue in. Yep. Thank you. Great discussion. I don't want to stifle any of it. Okay, so I'm just going to flick through a couple here. We've got now the second case study, and this particular case study again, and Derek's going to talk to us to this, and he knows this case very well. Again, is a real case study, and it's quite a complex case study, but not I don't think an unusual one for those of you who, you know, I think you all can relate to this. He's going to talk to that, and then we're going to have a little bit of a, we don't have huge amounts of time, but what we're going to do with this one is we're going to do it a bit more of as a collaborative approach. We're going to step through some of it to try and help, because the next two tools you'll get a feel for are quite different to the clinical tool as outlined, you know, earlier. But we wanted to give people a bit of an opportunity to get a feel for those as well. So thanks, Derek.
Thanks, Jess. So yeah, we'll do the second case study. This is the detailed health journey mapping. So yeah, I was privileged to be involved right through this man's journey. So yeah, we've got a 66-year-old traditional Aboriginal man from Tennant Creek in the Northern Territory. He was transferred to Flinders Emergency Department from Alice Springs Hospital with MedStar due to emphysema, gallbladder, and likely non-STEMI and STEMI. So yeah, medical background there. Had a stroke in 2011, hypercholesterolemia, GORD, and diabetes. So yeah. On arrival to ED, the patient was declining rapidly, so he was pretty much rushed straight into ICU with septic shock and possible active bleeding. There was findings there which resulted in esophageal cancer basically. The patient was also noted as agitative and combative, trying to get out of bed, and this patient had no escort with him at the time as well. Now, only up until day 6 of this admission into the hospital here, the patient was identified in medical admissions as Indigenous. So for those first 6 days, I knew nothing that this man was here laying in ICU, and it wasn't recorded on EMR. So yeah, once I got the call that day, we amended that. So yeah, the patient spent 6 days in ICU, intubated, and yeah, diagnosed with those new findings there of esophageal cancer. On day 6, that day he was extubated. That's where I went along and was able to, I guess, start communicating with this gentleman. So he spent 10 days in ICU before being transferred to a general medicine ward. And it wasn't until day 26 of this admission that the patient's daughter arrived from the Northern Territory. So, yeah, those 26 being very lonely. And yeah, the medical officer, the team basically was requesting to discharge to a local Aboriginal hostel and have obviously further outpatient workup and etc. I strongly intervened in that case and again strongly advocated for the patient to stay in hospital as I raised concerns around mobility, dysphagia, and he was also picked up to have post-extubation delirium. So with the supports from myself and the team, providing education, continue education and obviously simplifying it as well, importantly, around the consent for further medical procedures. So such as a PET scan, we know this isn't done here on site, so that requires going to the RA. I was able to attend there, which was really important that day, and yeah, further endoscopies occurred, and he had a stent put in as well. The team and I provided great support to the medical teams that were involved, and around the appropriate treatment options such as radiotherapy versus chemo. So in particular, this man chose radiotherapy, and that commenced. So we had numerous team meetings around the plan for discharge, and again it was still trying to be sort of pushed out at the time, but yeah, strong advocating from myself and the team basically deemed that he was not suitable to be discharged to a hostel, and he required obviously further medical intervention, and the daughter also requested that he continued in hospital for treatment in Adelaide as well. So again, with strong advocating, we was able the second time to get this man accepted into inpatient rehab. The first one was basically declined due to an improper assessment. So yeah, that actually occurred. And on day 18 at the ward, the patient accepted obviously for the rehab, and across we went to the ward there in rehab. The liaison attended daily to that rehab and made sure that they was present around the progress around his gym with the physio, OT and speech. And he spent 19 days in inpatient rehab, and after 57 days in hospital, the man was finally transferred back to Alice Springs Hospital under palliative care, and he did return back to country. So, and in that time he did make that progress as well, I guess, to survive ICU in the start, and again to sort of have the treatment such as the radiotherapy for the 4 weeks, and be accepted for the inpatient rehab just to get somewhat progress to be stable enough to be transferred back home and spend time with family. So that was really important, and again one of the keys in this is utilise the Aboriginal health staff that you have. Thank you.
Thanks, Derek. So quite a detailed journey with us for quite an extended period of time, and lots of layers to that. So we thought it would be good, to sort of have a look now at the detailed mapping tool in front of you. So that's the brown tool. Yep. And if I bring this up for you, yeah. So if you want to just talk to,
So one thing I didn't actually say earlier is the tools actually come in a couple of different formats. So the main one, which you've got printed out and that we're going through today, is the Excel format. And so this is one where you can just input all the information into the cells. But there's also a Word and a PDF one, which are just different forms to complete. But this one is a little bit better to go through as a group because it's just all on one page and a bit more together. But if you go on the Lodge website, you can see the others and check them out. So the detailed tool, as I explained before, follows the 4 steps: look and listen, think and discuss, take action together, and then review. So like the clinical one, in the look and listen stage, you stop and just have a think about the mapping process and how you're going to conduct it. So what's the reason for it, planning how it's going to occur. So it's got some little prompts there. So is it where it's occurring, who should be present, thinking about language and such. And then also like how you're keeping people safe. So that ties into those 3 underlying principles of safety, equity and partnership. And then you go through and identify specific focus areas of the journey which you wish to look in more detail. So for this specific case study, we can have a think of some focuses. So which ones did you want to go through? Did you have names for? Cultural safety.
Because I don't know, Lisa, probably good to point out, I think sometimes when we see these tools and we see all of the listed areas, we think that we have to go into all of them, and then that automatically starts to put a barrier up to think, oh, well, I don't know why that one fits. And I think the reality of that is that you don't have to do all of them. It might be one specific element that you want to focus on and really unpack.
Yes, that's a great point. So the ones which are there are just examples, but you can add your own. And again, there's a lot of cells on this. You don't have to complete them all. They're just like prompts to kind of guide the mapping process. So cultural safety, for example, you could fill out, and then you go along the side, and there's actually a little drop down, and you can't see it because it's quite small right now, but it's got all the focuses that you've got typed in this top section. So you can then click on cultural safety. And then you'd go along and input information about what's happening regarding that. So is there anything that we want to put in or ask the group?
Yeah, let's put it
Does anyone have an example?
What is happening from a cultural safety point of view?
In this case study?
Isolation from the community. That was a traditional male.
I can't
Yep.
type one-handed.
And just remember, he's obviously was not identified on arrival as well, on EMR.
I'd say language as well, being from the territory, you might speak Aranda or Warlpiri, someone here may not speak that.
Yeah, do you want to take that?
Yep. Other things too where, again, I guess, the patient deemed as behaviour sort of issues, and it wasn't picked up, I guess, until at least 2 or 3 days post being extubated, that it was the liaison that picked out it's not behaviour, it's actually something else. So that's when it was delivered that it was delirium. So little that sort of got missed, and again labelled as that non-compliant and behaviour sort of issue as well.
Not having the support like an escort.
Yeah, that's right. Not having his daughter arrive until day 26 into that admission. Yep.
Sorry, I meant to be relaying that, aren't I? Sorry, that was not having daughter present. So we've got quite a few in there already. You can see, oh, that's a loud one. Isolation from community, the fact that he's a traditional Aboriginal man, there's some language barriers that have been identified, the behaviour being labelled as non-compliant when, there was a delirium, and not having the support or family member as an escort. So, I think that captures cultural safety for that one. Quite a lot.
Do you want to go through any other ones? Mm-hmm. So, what does this mean? So, if we could compare it to some standards or policies, does anyone have any ideas of what these things could mean in terms of his care and how it's affected?
I guess not picking up things like mistaking his behaviours as something else when really it was a delirium, probably potentially could have prolonged stay if we're not treating delirium or tracking delirium appropriately at the start.
Yeah, good one. So that was around delirium and not being able to pick that up and what that implications might have had for his treatment and perhaps, his care overall. So it's good. Sharon, if you yell,
I can yell. The fact that he wasn't identified as being Aboriginal on arrival meant that he didn't have the support of the Aboriginal liaison officer for that whole period of time.
Yeah. So that's critical, isn't it, really? Yeah. It's a critical point. Okay.
Yep.
Sorry.
If you think about the safety, there's no two-way communication there because of the language barrier and even the intubation and the lack of a support or liaison. That was really missing as well.
really good point. There's no two-way communication. Yeah, it's critical. Okay, key point.
Summarise that? What would that be? Does anyone have a comment?
I think it all leads to, like, if you're looking up there, it says KPIs and data. From a business perspective, him not being identified led to a longer length of stay. And if he was identified initially, his daughter may have been able to get here quicker. So all of that, even from an organisational point of view, makes the length of stay, his treatment, a lot longer than perhaps it needed to be.
And potentially really inappropriate care, like if the Aboriginal liaison officer was able to help support staff to understand where this man might be coming from, what his understanding of healing, etc. is. So he could have been experiencing care that was inappropriate.
And I think also it de-escalates his concerns and fear. You know, because a lot of community members, you know, there is it known if you go to hospital, sometimes to certain hospital, it may also be, you know, they think that they won't go home, you know, and that's the last time they may see loved ones. Yeah, fear.
Yeah, fear, absolutely. Fear.
De-escalating. De-escalate.
Yeah. And there wasn't any in this particular case, I don't think, Derek, you know more, but particularly good links back, you know, the previous case had those links with the community. So this man, you know, when you unpack that, has essentially presented to the clinic with quadrant pain, and then in a matter of days he's, you know, come to Adelaide. He might not have ever been to Adelaide, like a city before. So quite quickly he's in a land completely foreign. Yeah.
Or even being on an aeroplane for some of our patients, yeah.
I think the comprehensive care, like the thinking about Derek requiring, actually needing to do such significant advocacy for receiving the right inpatient care, and also advocating by the sense of it for getting rehabilitation where he nearly would have missed out on that opportunity. Like there's a few situations that were missed.
Yeah, and I'll also say there was certainly a lot of times where I felt my input was not valued by teams and clinicians. Yeah, so I guess with persistence and you know, that team support and passion, yeah, I just kept pushing, and it resulted in accepting of the inpatient rehab. So, you know, and again, just that utilising the staff that we have is one of the key sort of messages as well. But you know, there's a couple other things, and like I said, we've only got certain information for you guys, but I think I had something like 6,000 words, sort of done up as a draft. But yeah, look, and it's not a matter of pointing the finger at anyone or, you know, any wards or anything like that. It's just awareness, you know, bringing the awareness out there that this is still sort of happening, you know, within this hospital. So, you know, before being extubated, he had a traumatic experience where the nasogastric tube caused bleeding and issues there, which obviously, you know, continued on as well. So, but again, that understanding, you know, look, at the time we were going through COVID, obviously, and still are, and at that particular time, patients were being tested on the wards. So again, for this elderly traditional man, I had to really simplify, you know, the information around COVID and the requirements of daily RATs and etc. So.
We've got a comment come up the back. Yeah, thanks, Emma.
Sorry, I'm Deb from ED. I'm a social worker. I think part of what we always have to remember is about the different cultural values of how we perceive health. And I think we need to marry that and relate it in a way that traditional gentlemen coming down from wherever, because it's totally different experience. And our language, what we relate to and what they may relate to is totally different. And that's where the Indigenous liaisons come in so important, because they can relate it in a way that we can't, that they will understand in a much more effective way. So language is a big thing, but also around cultural values, and we all have a different perspective around health, and we've got to respect that. Thank you.
Sorry, Jess, I think there's a comment online as well.
Oh, yeah. Someone online.
We've just got a comment here saying, well done, Derek, for continuing to advocate. So just wanted to pass
Thank
that
you.
on.
But yeah, just another thing just to share. And again, it's not pointing the finger or having a go, but look, there was a day there where I got called basically to say, hey, look, the patient's been non-compliant, and it was around having a gelco inserted. So I've gone to the patient. Obviously, there's language barrier, which was an issue. Maybe things weren't clearly explained. So yeah, I had a look, and basically within a couple of minutes, I thought, oh well, I'll grab the NUM or the coordinator, who then got a senior nurse to only sort of come back, and we found that the patient had a gelco already in the other arm. So, but it was documented already. So, yeah.
And I think that just emphasises these tools are also meant to be used to identify strengths and gaps in care. And so they're not meant to be used to point a finger at anyone and create blame, but they're identifying what's working and what's not, and then coming up with strategies to address that, and then reviewing the effectiveness of that.
Can I ask if there was an outcome to whether there was some sort of follow-up to why it was not documented in the first place, and whether there was some work done around that?
Yes, yeah, thanks. I asked those questions. It was hard to sort of pinpoint, and I respect, I guess, just the timing of, I think it might have been a Sunday admission, at whatever the time. Obviously, we don't work on the weekends as liaisons. So, yeah, I can sort of see that it was easily sort of missed, but I guess, to me it'd be features, would sort of be a giveaway, and knowing that he's from Alice Springs, surely there would have been some medical information that came with this man. So I do feel that it just wasn't, I guess, a concern or looked at.
We as a team are actually actively offering Ask the Question training now, so that staff can actually go out and ask the question, because it's not always about features, but you do need to ask, and then enter the data in the right space. And then we're encouraging clinicians to also ask the questions, because we know that the indigenous identifier within the next step system is actually 3 screens down, so a lot of information.
Yeah, I was just going to say the same. I mean, I think, hearing this story is a really powerful thing, because it then helps people to understand why it's so important. By actually you think, oh, well, we know he's Aboriginal, but if it's not in the system, then you can't pick that up because you can't, visually see everybody in the hospital. So it's
another big thing too,
so
that this patient had no GP listed on EMR.
So then that begs the question about the discharge summary. Where does that go? How do we have continuity of care and follow up and make sure that these people are looked after they leave the hospital if we don't enter that data?
So there's a question here from Kirsty McDowell. Was there any handover, staff undergoing asking the question training?
I think that's kind of part of the prompting for why that program is being why that program is being reinvigorated, because I think there's been an identified need through a number of case studies that are familiar to this. So yeah, I'd say yes, training's currently happening. Correct. So encourage your staff. Yeah, encourage your staff to join in on that on LMS. Yeah, in the interest of
question about how people book into the training
through the learning management system. Thank you.
Learning management.
So just returning back to the tool, so the next step would be to identify particular actions or things that you could do to improve this situation, and then you'd actually record these and evaluate the effectiveness of that. So that's the next step. And so then just moving on to the strategic tool. The start is quite similar to the detailed in what you record in the planning section. But then instead of recording the different focuses of the journey, such as cultural safety, you actually record specific stages that you want to explore. So for this one, that could be background. What was the next point? Present to Tennant Creek.
Yep.
and then I type slowly one-handed. And so then you put those and you could, do the specific dates and times. So this one might be used like over multiple occasions. So you might map them, when they get to Flinders, but then there's multiple stages that are going to keep happening. So an idea of this is even just having like one person in charge of like the mapping, and that's why you can have like different people and different times of each stage being mapped. Again, you click on these, look to which one you want to go to. So say at Flinders Medical Centre. And you can specifically record what's happening in the healthcare journey, what's happening in the family or carer journey, and other life priorities. You can include the patient's perspective of what is working and what's not and what should be improved, the healthcare services perspective of what's working, what's not, and what should be improved. You identify the gap together, so bringing those results into one, and then you come up with an action, record when the action's taken, and review the effectiveness of it.
Thank you. This, I guess, using a mapping throughout different stages of someone's journey, I think would be super beneficial. Derek and I actually worked with an Indigenous male from the Northern Territory who actually attempted suicide on the ward here at Flinders, which everyone thought was related to his admission here at Flinders. But yeah, with Derek sort of being involved and looking into it further, the issues were actually related to something else in his life, but sort of, he came to Flinders and we sort of just looked after him and treated him as a person that's only who he is at Flinders, not, I guess, someone, that has his whole other life and a whole other background and a whole other journey prior to just meeting us at that one point in time. So potentially using like a tracking tool at, different stages of someone's journey, then we can get like a much broader picture of that as well.
Thank you. Thank you, Lauren.
I'd also like to bring it back to the National Safety and Quality Health Service standards. This is a tool to help hospitals become accountable for the safety of patients, to ensure that they get home safely, to ensure that you're providing the best quality care. And this is a tool to help for the hospital reporting as well. So it's really, really important.
Thanks, Kim. Do people have other thoughts? I mean, again, it's thinking about how this could be, I guess, embedded within your areas, and if, it could be done in a way that's a routine thing that's done, you might do a spotlight on it, every few months. It's built into how you report out in lots of different ways. It could be something that forms in that way, or that you've got someone that's come into your area and you think you want to look at how you're going. It could be a good way to track, how we meeting the needs of this patient and what can we do with them, because you can see the power. And going back to what Jane said earlier about the goals of care, how this provides a tool to have that conversation with the patient to say, let's talk about what your priorities and needs are, and let's talk about it and marry the two up together. So I think there's that real power in the real time to do it, like the guys illustrated quite nicely, before a patient, if that plan, those ones that are coming for more planned surgeries, you can start the ball rolling in that sense. But certainly if you have the idea of this tool being something as, part of your workplace, when you do have a patient, thinking, how are we going to do this together? Sit down and take staff on a bit of a learning experience. It's a good snapshot to see how are we actually going and what are the gaps. So using it in real time, I think, has a lot of power. And then, of course, those ones that the patients that do get discharged and you think, how did we actually go? Can we, because it's not until and we don't do that often in health. Once people go, they go, and we're on to the next. And I know why that is. It's because we're extremely busy. We're not programmed to kind of think about our evaluating how we did. But I think if there is a way that can be built into planning sessions with teams, or, thinking about how can that be done, even if it's twice a year, but it's a tool that's then looked at, as at a bit of a snapshot to see where we're at, what could we do better, then do it in another 6 months and see how you're going. Is there a difference for that patient? I think that's the strength that this provides, because I know you're all here, you've all come along. There's a vested interest in wanting to do things differently and better, but I think sometimes a bit of knowing the how, and I think that's what these tools can kind of help provide some of that opportunity to do that. Yes.
One other comment. It's also being aware of the militant language that's coming into the healthcare system and services. When you talk about discharge planning, it's a militant word, discharge. It's very army kind of focused. We need to also look at the language. Perhaps it could be called the transfer of care. Then that shifts the thinking around, well, this is a transfer of care. I'm not discharging the patient and that's it. I need to be mindful of the whole holistic service that the hospital is providing. And again, it's a responsibility of the hospitals to ensure the safety of all patients that come through, and hospitals have to report to it.
Thanks, Kim. Yeah.
Just one more thing with all three tools, it can legitimise a conversation. I know as clinicians, sometimes if you're sitting bedside and you're trying to gather information, it's like, oh, you're not doing your work, you should be doing, your other 1,000 bits of paperwork. This is a legitimate tool to sit and have a conversation. You can spend 30 seconds, you can spend 30 minutes talking to someone, and just getting to know and building that really small rapport makes such a big difference. We've also had feedback that people may be able to use, can use the tools to track unseen work. So sometimes with our Aboriginal health practitioners, Aboriginal liaison officers, so busy, so dynamic, going here, then everywhere, and their journey throughout the hospital, it can track their work and shows the unseen work that people do. Yeah.
Is it uploaded to EMR as well?
Something we haven't explored. No, like I said, this is the sprout. But, depending on people's level of interest and where we can take this, certainly, there's the sky's the limit, but I guess this is the starting platform of that. Yeah. Yeah. And that's, I think, what Amy said. I think that's a really nice thing. I think it's also about we occasionally do get it right, but for whatever reason that doesn't get looked at either, and there could be elements in that, and it's probably often the people that were involved in that journey that did some wonderful things, but that's really hard to share and make it more across the system unless we know what it was that made that work particularly well. So again, it's another way of visualising what were the enablers of making that work really well. Another way to celebrate it as well when on the odd occasion I think it does go well. Other people got thoughts? We've got, just looking at time, yeah, we're getting close to the end.
Yeah, I just wanted to say too, just if I can, just a message again, but I feel it relates to, how it's worded, but it can only happen if we all work together, and I think it relates to the tools as well, so, encourage your staff to reach out and think about what can you do to make that difference.
So I guess I just want to put out now, we've got 5 minutes and there's probably some other questions. I'm not sure if there are other questions online, Constance, but again, a very, very quick, we didn't get our hands right into the detailed and the strategic, which, I'm sorry for that, but I think, there's other opportunities for us to do that. But I just wanted, I guess we've been having some lovely conversation throughout, but are there thoughts from people that this is seen as, a practical or viable thing to be able to take back to your respective areas to start unpacking further? Getting lots of nods, that's great. Yeah, Kathy?
Do you think this could be used for patients that are in the community, consumers as well?
Oh, absolutely.
To be able
Yeah.
to unpack the journey of people.
Absolutely. I think it has it's, absolutely, I think, and that's the intent. I guess I can't speak for that.
Just based off that question, it's not just for Aboriginal and Torres Strait Islander people, it can be used for everyone. And there's a saying that Janet normally says that if you can get it right for Aboriginal and Torres Strait Islander people, you can get it right for everyone.
Yeah, that's sure. So, do people have other thoughts? I mean, I'm keen to sort of keep the momentum with this. So you will, the people that have come along today, you will hear from me again in terms of trying to establish something with this to continue on, because I really want to support you in the next steps in terms of taking it forward. But do people have, you know, and I think that you guys have, you know, this is a tool. I think I probably should also say that there's, through the Lowitja Institute, which is the peak body for Aboriginal and Torres Strait Islander health research in Australia. They do really fabulous work, hence why you guys are obviously affiliated with them. They've got huge amounts of tools and resources there. And through the work that Janet's done, they've formed a community of practice with people nationally who have an interest in this tool. And I would say probably it's, you know, we have the opportunity here in Silen to sort of be leaders in this space, to, you know, sort of support the tool uptake, look at it in terms of, you know, community across the whole continuum of care in different contexts. And I think Janet would be keen on that too. But certainly I think we need to look at how, because I guess the last thing I would hate to see, to have some momentum, everyone come here enthused, and I know what happens, having been to many of these things, they come and all enthused and it makes sense, and then you go back to clinical practice and it all becomes really hard. The implementation is hard, right, which is why there's the delay in health with knowledge translation. So if I can, yeah.
Can I just ask, are other health services using it?
Yeah,
Like
good question.
Because
the RA's using it in their liaison office for some of those journeys, those more complex journeys. I think you guys had mentioned, and I think the renal space, is that right? They've started using it, and maybe ICU.
I think they were looking at using it.
Yeah. So. And I know Health Translation SA, they put out a spotlight on it in one of the recent newsletters. So that organisation is aware and was one of your partners, supporters. Yeah, yep.
It's also been trialled in different settings. So, for example, we had a staff member, a manager in the renal unit at Port Augusta.
Port Augusta use it, and she was going away, and she actually mapped the invisible work that she did to ensure that patients do get back to the communities safely. So all the behind-the-scenes stuff that she did as a manager of the renal unit, she used this tool to map it, to map what she does, so that when the next manager came in to take over while she went on holidays, she knew exactly the relational network, she knew exactly what to do. But this is information, and this is work, or the emotional work and labour, or the extra work that staff do that's not necessarily captured. So she used it for that, which would then she had the evidence there to show the extra support and resources that they needed. So she was able to map that and show that. So it has been trialled in different places and spaces, and it's been adapted. And if you Google, you look up Managing Two Worlds, this is actually where this map came from, which started in 2008. So it's been a long journey, and it's been from work from that time. So it's all there. Join the Lowitja Institute, become a member, and have access to the most amazing reports and resources that are developed and led by Aboriginal and Torres Strait Islander people.
Okay, just put it to the floor for the last, I think we've got a couple of minutes. Yeah, we've got 2 minutes exactly. Do anyone, there's a couple of, 2 minutes, you're giving me the 2. Does anyone else have any thoughts or something they'd want to share? Yeah.
I just want to say I think this is a great tool that I guess as allied health clinicians we can very simply walk away, and whether it's, you know, specifically using this tool, but even just, you know, we all have sort of initial assessments, and often we do look sort of beyond just what's going on medically for a patient, and we go into, you know, lots of social history and daily tasks and that sort of thing, you know, social work as well, looking kind of at more a holistic look anyway, maybe just not into this much detail. So even if you just have the spreadsheet for the prompts or the cues to then embed into our own initial assessments, it's quite an easy thing to ask a few more simple questions that could change someone's kind of whole trajectory in the hospital.
Thank you. There's also some work that's being undertaken in terms of silent research projects that are actually using these tools to capture patient journeys as well. Russ over in the corner there, sorry Russ, put you on the spot, but he's working at looking at an audiology evaluation out in the community clinic, and they'll be using these tools certainly to capture that journey and experience. So it is a good, I think I think we've probably hopefully highlighted that it has lots of versatility across, all aspects, continuous and quality improvement. Putting up proposals for different initiatives, that it provides a really nice evidence platform to support, the work that is undertaken at a high level, as well as, the day-to-day operations of clinical work. So, I think there's huge potential. It's a matter of now, starting to share the word and start to get some of that experience and sort of applying it into clinical context and supporting each other in how that looks and how that works. So I just want to take the opportunity again to thank the support that we have here today, Janet's support as well in terms of the work that, obviously the passion is there to sort of improve Aboriginal and Torres Strait Islander health, which, I think if we all acknowledge that the health disparity that exists, and we can't, pretend it doesn't exist, it does, and it's kind of at the forefront. We have a responsibility to, in not accepting that, do something differently, and I think this provides a good platform. Before you go, we'd really appreciate, we've just got a bit of a quick evaluation to fill in if people have a few spare minutes. Otherwise, we'll still be here for a few minutes if people wanted to come up and have further conversation. But otherwise, you will be hearing from me. I know where to find you all, but I look forward to, and thanks again for all of your support in coming today. So thank you.